I want to thank you for allowing a nurse to come before the committee and speak for the frontline caregivers, the nurses and healthcare workers in Pennsylvania. My name is Maureen May, and I have the honor of serving as the president of the Pennsylvania Association of Staff Nurses and Allied Professionals, which represents over 11,000 healthcare professionals across the state. PASNAP was founded 25 years ago by nurses deeply committed to advancing patient-centered care and to safeguarding caregiver voices and protections, not just for our own hospitals, not just for our own members, but for every patient across the Commonwealth of Pennsylvania and for every caregiver. I have been a direct care registered nurse for over 40 years. In my time at the bedside through the ravages of COVID and the rapid corporatization of healthcare, PASNAP commitment to patient-centered care has never wavered as patient care has evolved. The tools around us have changed, though, but our commitment to our patient has not. And this is the lens through which bedside caregivers evaluate AI and why I am here today. Last week, ahead of my testimony here today, PASNAP surveyed our members about AI at the bedside. Individual replies varied by position or hospital, but there was one overwhelming theme. Healthcare workers are deeply concerned, profoundly distrustful, and almost entirely shut out of the decisions about AI at the bedside. A nurse in pre-cert shared this with us. The in-service regarding AI was less than 1 hour, and no feedback has been requested since the initiation of the new process, which could be dramatically changed. Minimal training, no checkbacks or regular evaluations, and no transparency whatsoever about how AI systems in healthcare are working or not working. That's what our members are experiencing, and that is not patient-centered care. In healthcare, innovation has served caregivers and patients should serve the caregivers and patients, not just the bottom line. And technology has to support, not replace, clinical judgment. The fact is, for many applications, like we've heard here today, imaging and analysis, AI is very good, much better than the human eye. But for many applications of AI in healthcare, has only an 80% success rate. That means AI gives the wrong result 20% of the time, which is a problem for us as caregivers. We need to make sure that clinical personnel are ultimately in charge of making clinical decisions, even if AI is in the mix. Our internal survey of 89% respondents said they didn't trust our employers to implement AI with patient safety and care at the forefront and priority. And that's why I'm here speaking in support of Representative Benkat's bill today. This distrust is not theoretical. It comes from what we've already seen. And at the bedside, I've been in direct care in hospitals for 42 years. When algorithmic acuity systems are used to assign staffing, it does not work. They consistently underestimate what the patient's needs are. Every nurse or any nurse who works with those systems say that their clinical judgment just does not match the computer's assessment, yet hospitals use those flawed numbers to justify staffing. Our members describe in-hospital transport systems that cannot recognize urgency. So a stat scan can be treated exactly like the same as a routine one. It happens to just go into the queue. Other members cited automated medication tools, which is the PIC system, we use that at times, won't release the medications and holds back, and that's a delay of care. These systems just do not understand priority. They just don't get the context. They're a machine. They don't recognize a crashing patient. They don't know when a stat order should leap from the front of the line, from the back of the line to the front of the line. And when something goes wrong, the liability falls on us, not the vendor, not the algorithm, and not the executive who purchased the software. I am not anti-technology, nor are my colleagues. Technology helps us service every day and allows us to practice at a higher level. But as a committed advocate for patients and frontline caregivers, we have a responsibility to look at how AI is being used in our hospitals, to evaluate claims that AI will enhance our bedside practice and improve the quality of patient care, and to actively protect our patient rights to the one-on-one care, privacy, and safety that they deserve. When caregivers are removed from decisions regarding bedside innovation, it's patients and caregivers that suffer. AI must be regulated and challenged on an ongoing basis to make sure that it is learning and helping doctors and nurses and other caregivers, not hurting us. This has to happen both here in Harrisburg and at the bedside. We know from our experience that we cannot rely on our employers to make sure that this is happening in a proper way. If AI is going to be in healthcare, and it already is, frontline caregivers must be at the table, and the state must back us up in protecting the privacy and care of all patients. Implementation of an assessment, we need to institute AI assessment teams at every healthcare institution to assess where and to whom AI should be deployed, and assess its successes and its failures. Training. Caregivers who are being asked to use the AI need to be trained on how the AI works to be able to assess how to incorporate it into their clinical thinking. Caregivers need to know up front, is this a fixed model? Is it not? Can it learn? Does it learn? What decisions are being performed? Does this AI, is it a black box? Because we know black box systems should be avoided when it comes to diagnosis and assessments. Protection of clinical judgment, and this is where my heart is. Clinical judgment and clinical staff. We need guarantees that AI will support and not replace clinical judgment. AI is wrong 20% of the time. There is no replacement for trained, experienced clinical professionals. That includes ensuring that clinicians are not held liable for AI mistakes. We need to challenge the tool. Given that the AI tool is 20% wrong most of the time, at that 20% of the time, we need to encourage our frontline caregiver staff at every institution in which AI is being deployed to challenge the tool, to override its decisions when it's appropriate or not appropriate, and in the best interest of our patients, and to teach it better. Privacy and disclosure is an issue. Tracking and surveillance is also an issue with us. We need institutions to be able to be transparent about the tracking of employees' behavior with AI and to what end they are doing so. Anytime staff are being recorded or tracked in any way, that needs to be disclosed. And protections, mostly for newer staff. Doctors and nurses and clinicians, in their first 2 years of practice, should not be using AI for their assessment and diagnosis purposes. From novice to expert, it's a practice that is built on many years of experiencing firsthand clinical judgment and looking at the patient and not looking at a machine. AI is here to stay in healthcare. The potential for improved outcomes is real. However, we need to recognize that the potential is not guaranteed. AI can either help us or hurt us. If our seasoned, experienced caregivers are not overseeing and teaching AI systems with sufficient training and protections, AI will fail in its mission and ultimately fail our caregivers and our patients. That's why PASNAP is in support of House Bill 1925. Thank you.